So Daniel, we get Daniel back again now. And Daniel's going to walk again to the corner of the room. And he's going to walk to the door. And you can see that he's not limping. And come back and walk this way. Great. And then one thing we try and do sometimes is get the patient to squat down on one leg. And Daniel is pretty strong. And so he's not bad at it. If you stand up again, please. But actually, you can see that a lot of things get in the way of that, including your core strength, your balance. It's quite a non-specific sign. So, Daniel, if I can get you to go back to the door now. If you walk back towards the door and turn and face us. Okay, and if you just stand a little bit forwards, come forwards a little bit. That's it, stand there. And if you can squat down for us all the way, just squat down. Great, and stand up again. So it's pretty rare that a patient with meniscal pathology is able to do that. So that is a really good screening test. And then walking in a squat position, duck walking also. If you squat down, yeah, and keep your back straight as you can for me. Great, and walk. Fantastic, and relax. You can sit on the chair for a minute. And so again, a patient with meniscal pathology is really unlikely that they're able to do that. They'll get pain at the level of the joint line. And again, asking the patient to put a finger on exactly where the pain is. It's surprising you can localize where they're pointing, sometimes the medial femoral condyle, the meniscus, the patellar tendon. You can localize things really quite accurately with patients telling you exactly where the pain is. It's not a substitute for palpation, but it does give you some idea. And then, Daniel, if I can ask you to turn the chair around again, there's another quite fun test that I find patients can often cooperate with when it comes to looking for knee pathology. Just move the chair back a little bit. Thank you very much. And so now stand in front of the chair and put your two hands on the chair. Great. And I can ask you to stand on one leg and bend the knee very slightly. That's it. And now twist from side to side. And this is the disco dance test, loading the medial and lateral compartments of the knee. Thank you very much, and stand still. And you can do that to check again. It's most sensitive for meniscal pathology, but obviously a patient with significant arthritis will find this very painful. And of course, it's really important to be sensitive to the patient's comfort and not to do anything that provokes pain further than is really necessary. And now if I can get you to lie down on the couch again, Daniel, I'm going to show you one other really important sign. In the acutely injured knee, there are really obvious signs. And just shuffle to the edge again for me. Thank you very much. There are really obvious signs of pain and swelling and sometimes instability. But one thing, sometimes when the pain and swelling has settled down, that becomes obvious in patients who present a few weeks after the injury, is a locked knee. And so Daniel is going to just demonstrate the locked knee. Daniel, if I can ask you to bend the knee very slightly. Less than that, it's often just a little bit bent, and you ask them to push down, push the knee straight. He's pushing, and he just can't. So that is a locked knee. That requires an urgent arthroscopy to unlock the knee and to restore the patient's function.